Last week, we explored the neurobiological underpinnings of psychological disorders, the material and the efficient causes, if you will. While these might represent the typical explanations when someone asks, why does this happen, or what causes depression, schizophrenia, anxiety, etc., we have been questioning this narrow pursuit the entire semester by considering the formal and the final causes as well. Now, a quick note here at the outset. When discussing the final causes of disorders, it may seem like one could be describing an intentional choice made on the part of someone who has a disorder. That is, someone chooses to be depressed, for example. Now, it's important to distinguish between the purpose, aim, and direction that a final cause points us to, and to avoid conflating that with an intentional conscious choice. In our exploration of sensation and perception in the last portion of the class, we explored the importance of embodiment, and we raised the question of whether our bodies were something we have or something we are. We can pose a similar question regarding disorders. Are disorders something we have, or is it a way of being? Let's take an emotion as a case in point. If I'm sad, my whole world is transformed. I am not simply a neutral self in isolation. By the way, when is that ever the case? With an emotion that's added on top. Being sad, even being happy, being depressed, being anxious, being excited, all of these are embodied ways of orienting to the world. One of the theories that we're going to consider this week is the notion that mental illness is socially constructed. We'll read an article this week exploring this theory with regard to the topic of PMS. But let's take a look at what this theory in general proposes. Social construction describes the ways in which our perception of the world, that is, what we pay attention to and how we understand the world, is influenced by social and cultural forces. In short, social construction is an acknowledgement that our habits of perception, that is, how we look, does not occur in a vacuum, but is situated within historical, cultural, and social situations. Even exploring the neurotransmitters that are involved in depression is itself a socially constructed way of looking. It's not neutral, it's influenced by our understanding of what causes it. We typically don't go searching for neurotransmitters or do brain scans until we notice something is off in people's behavior. But what is considered abnormal and what is considered normal? When we apply this to psychological disorders, we take a step back and consider what are we paying attention to, and the flip side of that, what are we not paying attention to? And what does this have to say about our society? In short, it's what we value as a society. Let me give you an example. We don't pathologize people who are super smart, or those who have photographic memories, or even those who are perpetually happy. We don't medicate joy, but we do medicate sadness. Now, in all of these examples, they're deviants in the statistical sense of being statistically different from the mean, the average. Now, clearly, the deviance from the norm is not the criteria here, but rather the value that we place on certain behaviors. So let's consider ADHD. Why is this pathologized? Some of the symptoms of this disorder include difficulty paying attention, hyperactivity, fidgety, impulsivity, excessive talking, and inability to remain seated in appropriate situations. And now it's mostly diagnosed in children, but since 2001, we've seen a sharp increase in the number of adults who are diagnosed as well, and the current estimates are that 3 to 5% of the population has ADHD. If you compare this to schizophrenia, which is at 1%, we might wonder, was it always this way and we just missed the symptoms or the diagnoses? Or has it been increasing over time? Now, if we take this up from the point of view of social construction, we can consider how we live in what's been called a diagnostic culture, which describes a propensity to diagnose and perceive everyday experiences through a diagnostic lens. Now, this can provide relief for some. For some people, it might mean that you finally give it a name. There's recognition, it's been identified, and is seen and validated by others. But it can also be stigmatizing and a burden. Now, Using psychiatric diagnoses is not just something that doctors, psychologists, and psychiatrists do, but it also extends to the lay people. Depression and sadness, compared to clinical major depression, might be ways that we use that diagnostic language in our everyday life. I might say that I'm addicted to my coffee in the morning, but do I meet the strict diagnostic criteria for addiction? I could even question, is caffeine even a drug of addiction? So as you start to think through other ways that this diagnostic language infiltrates our everyday language, you might be thinking about how we often say we're depressed when we're just feeling sad or disappointed. We might describe ourselves as being schizophrenic when we're having mixed feelings about something. We also could describe our situation as being manic when we are eagerly occupied with a task. One of the implications of the spread of this diagnostic language and diagnostic comprehension of human suffering is that other ways of understanding the human being, that is, social, existential, moral, and even religious ways, are becoming less influential over time, and the overall palette of understanding, and also importantly addressing human suffering, tends to narrow along with this. For example, health is often defined in a negative way as the absence of symptoms. Isn't health more than the absence of disease or symptoms? Medical anthropologists have pointed to the biological, cultural, and social political factors that underpin different illnesses, as well as the medical reasoning that shapes our experiences of these illnesses. One of the things that social construction points out or highlights is that illnesses, our response to it, our understanding of how to treat it, our own experiences of those illnesses, as well as the social institutions that arise to address it, are all systematically interconnected. So let's take a look at how this emerged in the case of ADHD. If we go all the way back to 1798, we have Alex Crichton, a physician, who was the first to describe these symptoms. Now, he described the children as, quote, the fidgets, who were easily distracted, they could not focus on any one object, and it was the first time that inattention was a pathological phenomenon. Fast forward to 1902, and we have Dr. George Still, who describes deviant children with deficiencies in volitional inhibition, and he equated this with a lack of moral control. Hence, the same set of symptoms was thought to be a developmental defect, and his solution to this, that is, his treatment for it, entailed providing children with a new environment to strengthen their responses to punishment in an effort to develop a moral conscience and conform to society's expectations and norms. But note how the treatment here aligns with the purported cause. When it's seen as a moral failing, the treatment helps alleviate that moral deficiency. Thus, enter Alfred Treadgold, who in 1922 described this set of symptoms as minimal brain damage, and he described this as an organic abnormality that affected behavior, specifically what he called anti-school behavior. That is, the children's shortcomings were most noticeable when the children were subjected to school demands. So the argument about how the symptoms of today's ADHD stay unnoticed until the demands of education exposes them are widely acknowledged. However, linking behavior and neurological impulses in the brain still dominates our thinking about ADHD today, which is a case in point regarding the narrowed focus on just the material causes. One of the treatments that emerged in 1930 was a spinal tap neurosurgery, but it caused severe headaches in the children that underwent this. So it was in 1937 when Bradley first administered amphetamine to these children that exhibited these symptoms. He noted that after taking the drug, they became subdued, they lowered their voices, they behaved quietly, and their performance was enhanced. The drug not only cured but controlled specific behavior. This was a huge milestone for the pharmacological industry. In the 1950s, drugs were used to not only adjust behaviors, but also to treat disorders. Notice how disorders here become equated with the symptoms. The symptoms are the disorders, and they're not indicative of any other underlying conflict or concern or related to a world, which are also other ways of taking up and understanding these disorders. We might also pay attention to how the number of life problems that get defined as medical problems has increased over time, and we could question if there's an epidemic of medical problems. If the medical practice is better at identifying and treating already existing problems, or if a whole range of life's problems are being diagnosed and subjected to medical treatment despite the dubious evidence of their medical nature. One answer to this question has lied in the process of medicalization, which is, quote, the process by which non-medical problems become defined and treated as medical problems, usually in terms of illness and disorders, end quote. That's said by Conrad, who's explored the rise of medicalization with this diagnostic culture that we've been discussing. Diagnoses increasingly demarcate what is expected and acceptable and what is considered pathological. Behaviors and emotions that were once defined as immoral, sinful, or criminal are now being diagnosed as medical problems, transferring them from badness to sickness. Now, different drivers for medicalization have been identified, and Conrad specifically calls attention to the social movements and patient organizations along with the rise of the pharmaceutical industry. All of these institutions promote and advocate for specific diagnoses. They have an interest in medicalizing certain conditions for either the benefit of legitimization and access to resources or profiting from selling the drugs that supposedly cure the disorder in question. Now, the main problem with medicalization, Conrad claims, is, quote, its transformation of many human differences into pathologies, end quote. It narrows the range of what's considered acceptable in human society, and it also lowers our tolerance and appreciation for the diversity of human experiences. One of the other implications of the rise of medicalization is that it locates the source of the problem in the individual rather than in their social environment, and it calls for individualized medical interventions rather than more collective social solutions. So the individualization of social problems can obscure the social forces that influence human behavior. If we zoom out and consider what was going on historically, we could point to the changes that emerged in the educational system in the post-war period and a rivalry between the United States and the Soviet Union. To avoid falling behind, politicians, educators, and researchers started to focus on changing the pedagogy, establishing stricter pedagogy that required greater discipline. The school counselor also entered the classroom in order to help the teacher identify children who were struggling academically, as well as referring them to a psychiatrist for diagnosis and treatment. In addition to this, new educational strategies were developed. Changes were taking place inside the classroom with the rise of standardized testing, as well as some energetic activities such as music and gym taking up less class time. This resulted in increased pressure on children's ability to concentrate on academic tasks. The gender gap in ADHD diagnoses can also be explored from a social constructionist point of view. More boys are diagnosed with ADHD, and this has been described as part of what has been called the feminization of the school that favors girls' behavior and a medicalization of boyhood. In looking at the changing landscape of childhood, social constructionists would also point to the increasing domesticization of childhood with the rise of TV, video games, and computers, with less time spent outdoors and an increased consumption of sugar, fat, and salt in children's diet. Now, to what extent all of these play a role in ADHD is unclear, but it illustrates all of the surrounding social and cultural forces that would be of interest to a social constructionist, highlighting how ADHD does not emerge in a vacuum, nor is it arising in an individual isolated from the world. Overall, our social construction of ADHD has revealed three social and cultural forces that have been influential in both the emergence of and our understanding of ADHD, influencing our understanding of the causes, the treatment, as well as the experiences of individuals who exhibit these symptoms. A pursuit of ADHD that only considers the nervous system fails to account for how we are embedded in a social cultural milieu, and it also neglects how this understanding itself is socially constructed. So let's take a closer look at how a neurobiological conceptualization of ADHD is itself rooted in social and cultural perspectives. To illustrate how influential these social forces are, let's take a look at an advertisement for Ritalin. Recall that Treadgold named the group of symptoms that we now call ADHD MBD, or minimal brain damage or minimal brain dysfunction, hence viewing this as a brain and nervous system disease. By calling it a medical disease, it can legitimize it in a society that values and respects a medical point of view. Now, at the very top of the ad, we have a juxtaposition of two ways of looking. Is this a medical myth or a diagnosable disease entity, which illustrates how this is targeted to a society that accepts as real any disease that can be proven to have a physical material cause. By locating the cause in the brain and providing medication to alleviate or remove the symptoms, Treadgold legitimized ADHD's standing as a real diagnosable disease in the sense that it can be pinpointed neurobiologically. Ask yourself, if no physical cause can be found, does this make your experience any less real? Let's take love, for example. It's really difficult to find the neurochemicals and brain regions involved in the experience of love. Does that mean love isn't real? And if we do find out what neurochemical soup we're swimming in that correlates with the experience of love, is that all that love is? Smith, in 2013, describes how Ritalin was first marketed for different conditions, including obesity, narcolepsy, and depression, but it found real success when it was introduced as a treatment for ADHD. Now, the company that manufactures Ritalin marketed the drug heavily in publications and films, and they even organized meetings for parents and teachers about hyperactivity. The advertisements were not only directed at doctors, but they also spoke directly to parents with hope for getting happier and much calmer children. This advertisement from a medical journal in the 1970s illustrates this point. On the one side is an angry boy playing with a toy which he has torn apart. With teeth clenched and eyes closed, the boy is pictured as being unhappy. The image is blurred as if the camera could not keep up with his movements. And on the other side of the page, the child is much calmer, reading a book and looking relaxed and quiet. It really seems to offer parents two choices. How do you want your kids to act? But we don't act in isolation. It's easy to imagine, given a different educational setting, a different classroom context, where sitting quietly and reading are not the primary focus or goal, the symptoms here would not be in conflict with that kind of goal, but rather be seen as beneficial, valued, and desirable, much like we see with Sachs's treatment of Witty-Tiki Ray in the other case study that we'll read this week. So in addition to highlighting the broader social milieu, social construction also points to the interconnectedness of all these different situations, entities, institutions, and settings. So we might ask the question, does psychotherapy work, or in other words, talking therapy, in contrast to pharmacological drug therapy? And if it does work, which type works best? Social construction can highlight the confluence of methods and results, that is, how we study and research these diseases, and the perspectives of science that gives value or lends credence to treatments, so-called evidence-based treatments. If I'm looking in a material physical way, and this is the only criteria for determining the effectiveness of a treatment, then this favors neurological and biological treatments, mostly pharmacological ones. However, psychotherapies and talking therapies in general can also be effective as well if we understand what we mean by effective. Now, in one study that combined multiple efficacy trials from a drug and compared those with efficacy trials from talking therapies, the results showed that patients benefited from both types, but how they defined the effectiveness varied drastically between the two treatments. If you ask about symptom alleviation, the pharmacological treatments by and far surpassed the talking therapies. Symptoms were alleviated, reduced, or completely eliminated by the use of the pharmacological therapies. However, if you ask the patients if they had gained further insight into their disorder, increased understanding about their perspective and the world and how they were understanding that world, those talking therapies were much better than pharmacological ones. They walked away with a better understanding of themselves and their world, in contrast to the same questions that were posed to individuals who had taken pharmacological drugs. So it depends on what you mean by being effective. Notice again how the symptoms become equated with the disease itself. If the goal is to remove the symptom, clearly the biological ones are favored. But if the goal is to gain insight and to increase one's understanding, talking therapies are much better. It depends on the goal and what we mean by being an effective treatment. So let's question to what extent mental illnesses are socially constructed. I want to draw from Thomas Szasz. He's a bit of an iconoclast and he is anti-medicalization, anti-medicine, but he does have an interesting perspective on mental illnesses. So take a look at this quote from one of his works. As you consider his perspective here, we should question how our understanding of mental illnesses are tied up in larger social and cultural understandings of what's considered normal and abnormal behavior. For Szasz, he highlights that mental illness is an expression, a metaphor that describes an offending, disturbing, shocking, or vexing conduct, action, or pattern of behavior. He also has a curious comparison to how mental illnesses are similar to biological diseases such as diabetes or heart disease, but he makes the point that mental illnesses are not found in the dead. Upon autopsy, could you diagnose schizophrenia? Probably not. It's a problem in the living. So he makes the distinction between a disease as something you have and a behavior as something you do. Behaviors, actions, thoughts, and feelings are all performed by the living. Mental illness, then, is a euphemism for behaviors that are disapproved of. So if we consider the final cause, such as what do we gain or what is the purpose of designating such and such a person or a behavior as, quote, insane or crazy or mad or even a mental illness, notice that by doing so, we are placing ourselves on the side of the sane. It's a way of reaffirming our own place and understanding in the world. Yet, dismissing those who act differently as meaningless prevents us from trying to understand their place in the world. Everyone, mental illness or not, meaningfully inhabits their world. People do things that make sense to them. If we say a schizophrenic is insane, incomprehensible, that what they say is completely meaningless, we are preventing ourselves from even attempting to understand how they inhabit that world and how it's meaningful to them. So our last example is going to draw on a case study of Julie, who was a patient of R.D. Laing. Now, Julie was diagnosed with schizophrenia, and she proceeded through 3 distinct phases in her life according to her mother. She was initially good, then she turned bad, and then she went mad. Now, Laing calls attention to our proclivity to dismiss what a schizophrenic is saying as insane, mad, and incomprehensible. The person experiencing schizophrenia, consider what it's like to be in a situation where people respond to you that way. If they call you insane, they dismiss what you say as incomprehensible, they call you mad. If people are put off or scared by how a schizophrenic is acting or behaving, consider how the person with schizophrenia feels in that situation. Let's consider a situation where someone starts speaking their inner dialogue. If you said out loud every thought you had throughout the day, that would be weird, right? But if you can't distinguish between that inner dialogue and someone else talking to you, such that you experience auditory hallucinations, this might shed some interesting light on what it might be like for a schizophrenic who has auditory hallucinations. Is it simply a cognitive mistake that they've misunderstood who it is that's talking to them? Or are they so estranged agentically from themselves that they are unable to identify their own voice as their own, that they're so distant from their self psychologically? So let's consider some of the, quote, mad things that Julia would say to Dr. Lang in the sessions that he had with her. One of the phrases that she used to describe herself was a tolled bell. Now, Lang translates this as a tolled bell, that is, a girl ordered to be good, told what to do, and now we could add, of course, that someone else rings a bell, right? And so she's receiving direction from everybody else in her life. She doesn't have any agency in her own life. She doesn't dictate what she does. She doesn't have desires or wants. They're all given to her by others. She is no longer an agent in her own life, hence calling herself a tolled bell. So there are multiple meanings here of both tolled and bell that she's drawing on that Lang helps illuminate as he takes a closer look at what this means to her. Rather than deeming this as crazy at the outset, he tries to understand what this means to her. She also calls herself Mrs. Taylor, as in tailor-made, to which Lang also adds, she's a tailored maid. She was made, fed, clothed, and tailored. Now, when Lang attempts to understand Julie, that is, not dismiss what she says, we can see that Julie understands what's going on in her life. Her loss of agency, being directed by others on what to do. Another example is when Julie says a child has been murdered and it might be her. And on the face of this, at face value, she's alive. That's a crazy thing to say. But that's if you take her literally. Metaphorically, Julie is calling attention to her own loss of self. And so once you're diagnosed, medication often silences the madness, cures them, if you will. And these treatments and our understandings of illness don't even allow for the possibility that they make sense. What they say makes sense to the person saying it, and it calls for us to dwell with them in their understanding, something that's often missing in the diagnostic culture.